is negative birefringence, and that is gout. We've got a Kaiser-Fleischer ring, which is the brown ring in the eye. You see that in Wilson disease. Remember that is copper overload, and if they ask you what laboratory changes you expect, you would have a decreased ceruloplasmin. I'm just blurting out some high yields as we go through this. These are clue cells, which are seen in Gardnerella vaginosis. Basically, it's an epithelial cell that's coated with the pathogen. This is an Aschoff body, or I should say Aschoff bodies. You see these in the muscle of a patient who has rheumatic fever. So this is in their heart muscle. Here we have Kirschmann spirals, which are seen in the sputum of asthmatic patients. If we can go back to Kirschmann spirals for 1 second, I also want to mention that I didn't include it, but you could also see Charcot-Leyden crystals. So Google that when you have some time. This is erythema multiforme. It's basically a target lesion that usually occurs on the trunk or the extremities. And a lot of people confuse this with Lyme disease, so don't make that mistake. Erythema multiforme, there's usually a lot of them. There's more than one. And the patient will have no history of camping or any other risk factors that kind of point you in the direction of Lyme disease. This is caused by herpes simplex virus. So if a patient gets HSV and then later has this rash, that's the causative agent. So just keep that association in mind. Here we have a subdural hematoma. It's said to be crescent-shaped, and it's along the perimeter. Contrast that to an epidural hematoma, which is lens-shaped. Something to keep in mind is that the etiology of these are very high yield. So with an epidural hematoma, it's a rupture of the middle meningeal artery. But with the subdural hematoma, it's the bridging veins that are involved. So that's something that you definitely want to know. Here we have melanoma. When melanoma is presented to you on the exam, they'll show you a picture like this. And something that's really high yield to know is that the most important prognostic factor or prognostic indicator is the depth of invasion. So how deep does this lesion go into the skin? Here we have Kahl-Exner bodies, which you find in a granulosa cell tumor. Kind of a distinct image, so take a few seconds to stare at this and become familiar with it. One of the ways that they go after the more rare and I should say lower yield tumors, such as the granulosa cell tumor, is to show you histological slides to see if you really understand what it is that you're looking at. Here we have a Phyllodes tumor, which is a type of breast cancer. It kind of has a leaf-like projection. That's how it's described. It's another good one to keep in mind because in clinical practice it's rather rare, but the histology is so unique that it becomes high yield for USMLE. Here's the classic butterfly rash seen in lupus. You could also have a discoid rash, which is not pictured here, but that's another thing that you might want to Google, be comfortable with as far as lupus is concerned. Here we have ulnar deviation and involvement of the MCPs. This is classic of rheumatoid arthritis. Not pictured, but something to keep in mind is that if it was osteoarthritis, there would be involvement of the DIPs. This is a CT scan showing polycystic kidney disease. You see the kidneys have numerous cysts in them. They're slightly larger than they should be. Something to keep in mind that's high yield is that this puts you at risk for a brain aneurysm. There is an association that you should know. These are neurofibrillary tangles seen in Alzheimer's disease. Kind of a rare image, or not rare, but a unique image, so definitely familiarize yourself with this. Here we have one of my personal favorites, and if you've seen my other videos, you know how I feel about basophilic stippling, but this is basophilic stippling. It's lead poisoning is the diagnosis. Here we have a rouleau formation of red blood cells, which is classic of multiple myeloma. So the red blood cells kind of form this stack. They should be more spread out, but in this case they're stacked on one another. Here's the Schiller-Duval body. Here we see multiple of them. This is found in the yolk sac tumor. Again, as I mentioned a few slides ago, with these rarer tumors, know the histology because you're very likely to see one of these. This is hilar adenopathy, classic of sarcoidosis. Anytime a question gives you a 40-year-old African-American female, the first thing you want to think is sarcoidosis and then go from there as far as what type of symptoms they may be experiencing, such as hypercalcemia, non-caseating granulomas, etc. This is a horseshoe kidney on a CT scan, classic of Turner syndrome. at first glance, you might look at the CT scan and not really notice what it is that you're supposed to be finding, because CT scans are very difficult to interpret if you're a newcomer, especially at the M2 level. You're not really expected to know how to read CT scans, but nonetheless, the CT scans that will show up on USMLE and COMLEX are going to be ones that are very, very unique in nature. And here we see a kidney that envelops both sides bilaterally, hence the name horseshoe kidney. Know this image. Here we have a hairy cell found in hairy cell leukemia, very aptly named. As you can see, the cell has these hair-like projections coming off, so if you had to take a guess on your exam, you might even get lucky guessing that this is a hairy cell, because it literally looks like the cell has hair. Here we see a heliotropic rash, classic of dermatomyositis. High yield to keep in mind with dermatomyositis is that patients with this disease have an increased risk of either developing a malignancy or they already have an underlying malignancy. This is a schistocyte. These are also called helmet cells. They are commonly found in DIC, HUS, TTP, and aortic stenosis, which is a rare one, but you should keep that in mind. Patients who have aortic stenosis kind of have a functional slicing of red blood cells that pass through that stenotic valve. So you actually can get an anemia secondary to aortic stenosis, and you're very liable to see schistocytes. Keep that association in mind. Not a lot of students know that, so it's kind of an extra point to bump you over the average if you can pick that up on test day. This is a multiple segmented neutrophil, which you will see in a B12 or folate deficiency. Here we're looking at situs inversus, which is classic of Cotagener syndrome. So you see that the heart is kind of mirror image flipped onto the right side. And of course, the mediastinum should be more towards the left. So in this case, we've got situs inversus. This is a CT scan showing a pulmonary embolism. The classic PE that may show up on your exam will be what they call the saddle embolus. It sits over kind of both sides of that bifurcation that you're looking at. So be comfortable identifying PEs on a CT scan. This is a great image. This is a Reed-Sternberg cell, classic of Hodgkin's lymphoma. It's got the owl eye nuclei, as they say, and it's a very, very high yield image. This is probably one of, if not the most high yield images in this 40 that I've picked out for you. Here's the lead pipe colon or lead pipe sign, which you see in patients with ulcerative colitis. Notice that the colon is rather flat, and it should not look like the lead pipe. So the reason we call it the lead pipe is because it's flattened out to such an extent that it's no longer really recognizable as the typical colonic wall. This is a Lewy body, which you see in Parkinson's and Lewy body dementia. Again, most of the images that you see in the nervous system or the neurology systems chapter, they're all very unique. So you do want to be familiar with them because they're very unique, and these board exams love unique images. This is the thumbprint sign. This is probably a top 5 as far as high yield goes in this lecture. We see this in epiglottitis. So in epiglottitis, the epiglottis becomes so inflamed that it takes on the appearance of a fat little thumb. Something to keep in mind, obviously, the number one pathogen we think of with epiglottitis would be H. influenza, so keep that in mind. These are Kimmel-Still-Wilson nodules. So you see these in diabetic nephropathy. They're kind of pink globs that sit in the kidney. Anytime you see this, you want to obviously think about nephropathy and diabetes. This is a teratoma. Teratomas are tumors that have multiple components to them. So in a lot of times you'll see teeth or you'll see hair and lots of different organ tissue types. So anytime you see anything that looks disgusting, weird, like straight out of a horror movie, think about a teratoma. Here's a seborrheic keratosis. It has what they call stuck-on appearance. It looks like someone took Play-Doh and just stuck it onto your skin. This is seborrheic keratosis. Steeple sign, just like our friend the thumbprint sign, anything having to do with the airway is super high yield, definitely top 5. This is in croup. It's supposed to look like the steeple of a building because you have subglottic narrowing. Here we see an apical lung cavitation. If you close your eyes and you hear the words apical lung cavitation, I want you to immediately think of tuberculosis. It should be number 1 on your differential. Here is a good one. This is a starburst appearance, which you classically see in the bone of a patient with osteosarcoma. It's a starburst appearance. Something that's not pictured here, but to keep in mind would be that if we had a different type of bone tumor, which is called a Ewing sarcoma, you would see onion skinning. So onion skinning is Ewing sarcoma, and starburst appearance is osteosarcoma. Be able to differentiate those. This is a Virchow node. This is a supraclavicular enlarged lymph node that signifies that there's underlying malignancy. Definitely high yield. Here we have the apple core sign. So anytime you see an apple core lesion in the colon, you want to think about colon cancer. And then our last slide, we're going to finish off with a meningioma. So there are a lot of different brain tumors that they can show you on test day, but one of the ones that they love to go after is a meningioma because it's really unique. The tumor classically sits on the periphery of the image. Some people confuse it with an epidural hematoma, but these are usually a little bit more hyperdense, meaning more white, more thick than an epidural hematoma. You can recognize these because since it's a meningioma, which means inherent and coming from the meninges, it's going to be on the periphery where the meninges sit, whereas other brain pathology would be more spread out.